Hello viewers, this is Health Now Show, your health friend. With me, Jane Kariuki. I'm so delighted to welcome you to this show that really looks at all aspects of your life pertaining your health. And before I go on, I would like to welcome and appreciate the new viewers from all over Kenya, and specifically those that are in Kisumu. We are in Kisumu, we are in Meru, we are in Nyeri, Nairobi, and its surroundings. We are here. So welcome. This is the show that really looks into life, as I have just said. And for this episode and the few coming episodes up as we go along this month of June, we are focusing on a very important day. The day when we bring awareness on the issues of the elderly. This month of June, we are having to mark the World Elderly Abuse Awareness Day, which is on the 15th of this month. And to take us through, because we have so many things that affect our lives as we go along. And we know that we start in childhood and we move on to old age, having been blessed with long life. And now, when we get to the old age, or the elderly, or the late adulthood, we look at issues that actually affect this group of individuals. From their mental health, from the caregivers that are with them. So that is what we'll be looking into. And even as we bring this awareness, because as we say on this show, we want to sensitize you. We want to create awareness on the issues that are in our communities that affect us, and then say there is help for it. And to start us off, we would like to look at the mental health of the elderly. When we talk about the elderly, we talk about, some people define them as 65 and above, others 75 and above, others 90, 95 and above. But we'll bring all these people together and look at what are some of their mental challenges that they have, so that we can also be helpful and supportive, respectively, so that we can be able to help them. We know that one out of 5 adults has a mental disorder or a mental condition. And if this is 1 out of 5, that means we have quite a number of us with these issues. And to take us through this is a clinical officer, a friend of mine, Agnes Gishohe. I'm going to allow her to introduce herself and then take us on this very important subject of mental health awareness on the elderly. Karibu, Agnes.
Asante sana, Jen.
Karibu sana.
Asante.
I'm happy to host you today.
Thank you.
Yes.
Thank you for having me.
Kindly introduce yourself to our viewers.
Thank you.
Yeah.
So our viewers today, my name is Agnes Geshohe. I'm a psychiatrist clinical officer. I am also a mother, and I work in the mental health field.
Okay. Oh, wow. So for how long have you been working in this health sector?
In the health sector, I'm clocking my 17th year.
Wow.
But in mental health,
yeah,
this is my 5th year.
Wow. Wow. Yeah. So issues of mental health are, a wide range from probably the young children. You could tell us probably the range that you usually deal with mostly.
Issues of mental health, we start them as early as they are noticed, from the very young up to the very oldest.
Okay.
So we look into as early as 2 years and as late as till death do us part with our bodies.
Oh, yeah.
Yes.
Oh, yeah. So this is a lifelong kind of a profession. Yes. More of supportive to all of us, because we are in between the birth and the death.
True. Every day you wake up, Jen, you're at risk of a mental health crisis. Yes.
Wow. Okay, so probably you can now take us through this journey of mental health, and especially looking at the elderly. What are some of the mental health conditions that are common with this group of people, of individuals? Yeah.
Is they're the very most common for the elderly.
Yeah.
And as you mentioned, we are not able to really have a clear cut who is old. But from WHO reporting, they actually classify mental health for the elderly from age 60. Others classify from age 65. So today we'll be discussing, let's put it at age 60, so that we capture even retirement. So the very most common that you and I have come across and in the community is what we call dementia. And there is also delirium. They also suffer from depression. They also struggle with anxiety. And let us also remember those people who've been having bipolar disorder, schizophrenia disorder in their early years, as they progressively get old, they go together with the disease, since these are chronic diseases. So, but the very most common are the ones that I've mentioned.
Okay.
Yes.
We will go to each one of them.
Yes.
So that our viewers can be able to look at that and even see what are some of the symptoms that probably they can look out for if they have somebody who is with them in the community, in our own houses, because I'm sure there are some watching us today that are having some 60 plus in their houses, in our houses, and there are some things that we can be able to relate with in terms of what you're going to say. Kindly unpack.
Yes.
Unpack some of those areas, for us. For us, yeah.
We'll go ahead and discuss now dementia.
Yeah.
Because it is the most common, it is the most understood by every other. One, I would want to say dementia is a mental health condition that starts with age, but it can also affect people of young age. So it presents with the loss of memory. That's the most common symptom. Then as it progresses, the client can start becoming confused. They are not oriented. They start claiming that either they've lost an item or somebody has stolen an item. They also present with a lot of agitation, irritability. They can also present with a depressed mood. They are looking sad all through. They are complaining. They are saying they are not taken care of. When they are needed to transact their business in the bank, they have forgotten their signature. They are not able to really comprehend activities at home. This in early stages before this is noticed, there is normally a lot of confusion and in the family. And people, the family members are not able to accommodate these the person, the patient. They are not able to understand why they are behaving the way they are behaving. And Jane, for early stages, you'll hear family members saying he's just losing memory because of age. But it is important to know that there are different there are different categories of dementia. The most common one is Alzheimer's, Alzheimer's disease, that is known to be hereditary. Some of the Alzheimer's disease, the causes are not known, but the major one is inheritance, which runs from through the family. The other one is called vascular dementia, that is brought about by high blood pressures or vascular issues. The vessels in the brain, when they have issues, so they can cause an effect on the memory, the concentration, the understanding, the thinking, the very higher center that we all rely on as human beings. Then there is the ones that causes bodies to grow inside the brain. We are using this so that our viewers can understand. So that we are not very medical. there are bodies that grow inside the brain, and maybe when a CT scan is done,
Yeah.
the things are seen in the brain and they are growing.
Yes.
They really inhibit the higher center, the thinking ability, the memory, but all of them, most of the time, they will present the same.
Okay.
Now, dementia and delirium are very related.
Okay. Okay.
But the difference would be delirium, you'll find that it is short, it occurs in a very short period.
Yeah.
And most of the time, there is an underlying disease.
Okay.
For example, the sugars have gone very high, or
For
they've
the
gone
diabetes,
very low. Yes, for the
diabetics, yeah.
diabetes.
Yeah.
Or the hypertensive, if the blood pressure goes very high.
Yeah.
Or when you're looking at the chemicals in the body,
Yeah.
you realize the electrolytes, the chemicals that facilitate movement of nutrients in the body.
Yes.
Either they're elevated, and this patient will be well, then all of a sudden they go into confusion,
Okay.
agitation, a depressed mood,
Yeah.
or they present with a lot of anxiety, or a patient who's just from surgery, and they will present with all this. They can start seeing things that others are not able to see.
Okay.
They can start hearing voices that others are not able to see. These and dementia, the symptoms are the same.
Okay.
But the difference is the time period.
Okay.
For dementia, it's protracted, it's progressive. It's progressive and takes a long time. You'll hear there's a history of maybe 3 to 4 years of slow memory loss.
Okay.
You can't remember where you placed your keys. You look at them, you can't remember where you placed your phone, like that, like that. But for delirium, it is sudden onset.
Okay.
Yes.
Now, I'm imagining that I can forget my phone.
Yes.
And where I am. So probably sometimes I will call it. So where is that? Yeah.
We need to consider the period, or the frequency of forgetting.
Okay.
If it is way too much, every other time you really can't find where you placed other things.
Yeah.
It does happen.
Yes.
It is normal to forget.
Yeah.
But again, is it now again affecting your way of living? Is it getting out of hand? Yes.
Yeah, because I've seen some elderly people.
Yes.
They are holding a knife, or and they're looking for it.
Yes.
And they walk around the house looking for the knife, and they're holding it.
Yes.
Yeah. Yeah.
Those are some of the things a family member can be able to pick. And in early stages, it is very well managed. But as it progresses, and then now they start now experiencing their cognitive function is affected.
Yes.
The understanding, the language.
Yes.
The hallucinations now, the perception is affected.
Yeah.
Then now that is the moderate. As it progresses to severe, then you realize now even the family struggles to take care of the patient. What also Jane would want to mention is that there is a lot of confusion in the community that because the way we are saying it is because of age, we think this disease should not be taken to the hospital. But it is important for us to know that there is help.
Yes.
There is help.
Yeah.
There are support groups that can be able to take these family members through and see how best to take care of their kin.
Okay.
Yes.
All right. So delirium, we have looked at it.
Yes.
Dementia, we have looked at it.
Yes.
We go to the next one.
Let's go to depression, Jenny.
Okay. Okay.
Depression is a learned helplessness by the brain. That I am not.
I think you can say that again. You can say that again.
Yes.
Yes.
It is learned helplessness by the brain. One of the symptoms, we say key symptoms are two.
Okay.
One, loss of interest in things that one used to enjoy doing. The other one is low moods or sadness.
Okay.
What people say, I feel depressed. Unfortunately, in our African mother tongue language,
yes,
we are not able to have those nice words we can use
yes,
to describe our mood. Some say I'm bored, some say I'm tired. But when you dig deeper,
yeah,
it is a sad mood.
Okay.
And for our old parents, they are not able to express themselves because they have not been raised knowing how to express themselves. That is one. Two, our language does not allow us room for the various description of our moods. And again, why should I bother people anyway? I am not functional. The other symptom could be loss of appetite or a very high appetite. They eat a lot, or they eat very little. They don't have appetite.
Yes.
The other one, Jane, is a lack of sleep.
Okay.
Complete deprivation of sleep or sleeping in excess. The other one would be lack of concentration. You're having a conversation, but you lose them. They are no longer interested. They want to stay alone. They want to avoid those meetings, those congregations. They want to avoid. Again, self-harm. Our old people really attempt suicide many times.
Kindly.
They attempt suicide many times. They contemplate about it. They talk about it loudly, but maybe we think they are just, they are just talking about their desire to part ways with people. But in truth, they really attempt suicide. One, they refuse to take the medication you're giving them. They know the uses of this medication they've been taking for a very long time, but all of a sudden they no longer want the medication.
Yes.
Or sometimes they take in excess.
If there's no supervision, nobody is watching. Yeah.
Yes. They feel they've become a burden to their kids. They are always in and out of hospital, or a pain here, a pain there.
Yeah.
And especially the kids who have long or chronic conditions.
Yeah.
The arthritis, which is very painful, pain every other day.
Yes.
It can predispose one to depression.
Yes.
Another risk of depression is the family wrangles, the confusion that comes in the family where people now start arguing and there's disagreement. Losses, when they start burying their children. And in African setup, you should never bury your own child. It is your children to bury you.
Yeah.
But when you start burying your own and you're being left grandchildren to take care of, Jane, it is not easy.
It's not.
With these hard economic times, they are also struggling to get resources to fund their wellness, to fund their, when they go to hospital, they are told, take a balanced diet, eat this, try the other one. They are not able to afford that. That's a stressor. Yeah. They come to hospital, but they don't know where to get transport back home. That is also a stressor. So all these things can predispose one to depression. Again, Jane, we mentioned that there are people who've been struggling with depression from a younger age. Then they transit with this depression into old age. Yes. That is also a predisposing factor of depression in old age. Yes. Also, persons who have had very traumatic life events, the abuse you're talking about, whether physical or psychological, it can predispose one to depression. Yes. Again, the lived experiences in the community. We've seen some societies abusing and even banishing the old, and some even killing them. That can be very traumatic to the living.
Like suspicion on witchcraft, I've heard about it.
Yes. Where does it leave me, the living one? And I've started, my hair has started turning white. So it predisposes me to fear and anxiety. And the next thing we're going to discuss, Jane, is anxiety.
Anxiety.
Yes.
Just hold it on that.
Right.
We'll take a short break, and when we return, Agnes is going to continue with now anxiety. Stay tuned. Welcome back, my viewer. We're still with the clinician Agnes Gishohe, and before the break, she was talking about anxiety with the elderly. So, Agnes, from where we left, kindly let's go on.
Let's revisit the bit that we left about depression.
Yes.
Depression can coexist with anxiety. And most of the times it does. Because you really don't understand why you're not doing the things the way you used to do. And you're tired most of the time. You
Yeah.
have lost interest.
Yes.
You're not motivated.
Yes.
So it can coexist with anxiety.
Yes.
Anxiety can also coexist with every other medical condition that one is struggling with. Because the old, the disease is not getting better.
Yeah.
And they are being told with age, this is common. And nobody wants to get old with a disease or in sickness. You want to be okay. Even if you're aging, you still want to be okay.
Yeah.
So you get anxious, you don't know what Daktari will say the next time you visit the hospital.
Yeah.
When you're checking the blood pressure for this client,
Yeah.
they are very anxious to see whether it is a bit different. Maybe they have really worked hard back at home to stabilize the diet, to improve the living styles, and they become very anxious. So what is anxiety? Anxiety is that feeling of restlessness. You're not settled.
Yeah.
You become fidgety. The heart beats much faster and you're aware of your heartbeat.
The palpitations.
Yes, the palpitations. You can actually sense your heart is beating naturally. We should not notice that our hearts are beating.
Yes.
But at that point in time, you appreciate your heartbeat, and it is in phases. It's goes on, then it stops. It fades away. Then after some time, it reoccurs. But that is very different from a heart condition. A heart condition, you'll have the pulsation or the awareness of the heartbeat all through.
Yeah.
And especially when you have physical exercises, or you engage yourself physically,
Yes.
you will feel the heartbeat now has become more pronounced.
Yes.
But for anxiety,
Yes.
it is in intervals, and you can tell that it is coming. Then it beats very fast, then it tones down. At that point, there is sweating, there could be tremors, you shake, you become very restless. Some even become confused, and they even go into a panic attack, Jane. So with all these, combined with the medical issue that the elderly are facing, and the environment they are. Remember, the nest is empty.
It is empty. It is empty.
The nest is, they are alone. They don't have somebody to distract their thoughts.
Yes.
So they can go on and on and on and on.
Yes.
And so, Jane, when we are saying that the elderly need to be looked into, it is because of all these combined and comorbidities that they really struggle with.
Yes.
So anxiety is a very common condition in the elderly.
Okay.
Whether sometimes it is noticed, but most of the time it goes unnoticed.
I was being told by somebody that the spouse trembles a lot, some at intervals, and that is what you're talking about. That I hear you as you say that, and now I remember that anatetemeka sana sana sana. Yeah. Okay. Go on.
Then it resolves.
Yes.
Then again they have another phase of an attack. So as this progresses, most of the time they visit the hospital because they feel like the chest is aching, or the chest is tight, or there's pain in the chest. That is looked into, and maybe they are told the heart is okay. So then the other thing to investigate in the medical field is, could you be having issues that you're struggling with? Could you be anxious? Is there something that is happening on the background that you've not been able to notice and resolve? So anxiety can be brought about by, as we mentioned, other conditions, other medical conditions. The medications that these elderly are taking can cause anxiety. Of course, family issues can bring a lot of anxiety, and especially where the individual feels helpless. They are not able to help the situation or to make resolve of the situation. The other cause of anxiety is progression, as we said. You've had anxiety in your early ages, and now you've transited to old age. And this is something that maybe has been on management for the longest. So you again go into old age with the anxiety. Yes.
Wow. Agnes, this is good stuff.
Yes.
Let us now look at what are some of the symptoms. You've mentioned quite a lot of them, but probably main symptoms that we can, as the communities, as caregivers.
Yes.
What are some of the symptoms that we can look out for? when we have this elderly in our homes and in the community?
Thank you very much. I think we will classify them into two.
Okay.
One, we can classify them as mood.
Okay.
And the other one, we can classify it as psychosis.
Okay.
So there could be a change of mood in this person. Either they are extremely joyous, very high,
very happy,
manic,
very happy,
very happy.
Yes.
Or they are very low,
Okay.
very low moods, very sad,
Yeah.
hopelessness,
Yes.
Feelings of worthlessness. They are mentioning that, I would rather be the one who died than that child. I would rather not live again. I'm bothering you so much. Those are some of the mood aspects that we would want to identify.
Yes.
When this person now starts going that direction.
Yes.
Or this disease is really bothering me for a long time. Why can't I just go? The other aspect is the psychosis. Psychosis is whereby there is change in perception.
Okay.
The way we perceive things.
Yes.
What we see, they will start seeing things that we are not able to see. They say there are people in the room, but you can't see them, Jane.
Natafuta naangalia. Hakuna.
Hakuna. That's what we call visual hallucinations.
Yes.
Then there is the auditory, what you hear.
Yes.
They might be hearing people calling them, and especially the people who have gone ahead of them.
Those people who have died.
Yes, those who have died. They will say, maybe Fulani is calling me, and yet that person already died. Or they can claim that there's somebody who is talking to them and telling them that you've done 1, 2, 3, Jane, and we are in the same house with you.
Yes.
But I can tell you, somebody is telling me about you. So those are the auditory hallucinations.
Yeah.
The other one is the taste. Sometimes they can take food and they tell you this food tastes soil or ash.
Na vile nimejipanga kukupikia.
Exactly. They can claim the food has a different taste, or the food is oversalted.
Okay.
Or undersalted.
Yes.
The other one is smell. They can claim either they are smelling bad or something is smelling bad in the house or in the environment, and for sure you can't sense it and you're in the same environment.
Yes.
The other one, Jane, is touch. They will claim maybe there's something crippling on their skin, or there's something moving within in their body, but you can't see what it is, or something is pricking them or biting them.
And I can imagine they can insist that it is actually there.
It is actually there.
Yeah.
But let us separate. There is the tingling sensation of the fingertips for the diabetic and the hypertensives and the alcoholics.
Okay.
On the fingertips.
Okay.
Tingling sensation.
Yes.
That is not hallucination.
Tell us.
Yes.
Yes.
That is not hallucination.
Yes.
So let us separate.
Yes.
That the hallucination we are talking about is either things crawling on the skin.
Yes.
Or things pricking them everywhere.
Yeah.
Yes. It is not isolated in one place. Then they can get delusional. They start believing maybe they are somebody different.
Yes.
Or they become very religious. They say maybe they are God, they are the prophet. Something that was not there before, so that we don't confuse people.
Yes.
You can be a prophet, appointed prophet.
Yes.
Yes. But this one who wakes up in the morning and claims that here I am. And you can see again the things that they are doing is not according to what we know a prophet does.
Yes.
All right? The connection, the spiritual connection is not in line with what you believe in or the faith they practice.
Yes.
It is not in line. So it is anything that is out of...
It's like an extreme.
Yes, an extreme of almost everything.
Yeah.
So so in the psychosis, you can have that. We can also have change of behavior. You see, maybe they've started collecting things and holding things that are necessary, collecting things on the street or in the compound, walking around aimlessly. And also, when now they start, their memory now deteriorates. When we were talking about dementia, they can wander around and not remember where home is. And we have seen our parents being announced on TV and social media that if you see them, please bring them back.
Yeah.
They wander around, they are not able to remember.
Yeah.
It is good to note these things. Then when there is, of course, change of the physiological appearance, poor appetite, refusal to, or weight loss,
Okay.
or again weight gain. Again in behavior, you realize they might start refusing to take a shower, self-care.
Yeah.
They don't want to brush their teeth and they used to. They don't want to take a shower. And if they do, it is just touching or just pouring water on themselves. Then they walk out and they say they are okay. Negativism, Jane,
Yeah.
you tell them, let's go to church.
Yes.
They don't want to leave the house.
Yes.
You tell them, maybe you're in a congregation, you tell them to sit, they want to stand. You tell them to stand, they want to sit. Negativism. Yes.
I think that one, Agnes, you can repeat.
So it's a scenario where they are not able to take up instructions.
Okay.
They are not able to take up instructions.
Yes.
They are not able to comprehend what you're saying.
Okay.
So you are in a conversation, or you want them to sit on another seat, and they don't want to move.
Okay.
They don't
and I
want to
guess
move.
it can be very frustrating for the caregivers.
It is.
And,
It is, Jen.
yeah.
It is a struggle, and especially even taking them to hospital. They say they are not sick. They say they are not ready to go anywhere.
Yeah.
They are not ready to prepare.
Yeah.
And it becomes very difficult to prepare them and take them to hospital. Sometimes we give them appointments. You tell the caregiver, please bring your client at 9.
Yes.
They tell you, Daktari, no. Let us come at 12 or thereabout. Because the process of getting them ready
Yes.
is very protracted. Even getting them to the car. Now, getting them out of the car to come to the hospital, it becomes very
Na
protracted.
amefikishwa kwa hospitali.
Amefikishwa hospitali.
Anakatalia ndani.
Yes. So it is not easy for the caregivers, and we understand, but we are always there for them.
Yes.
So that we can give them advice on how to work with them, and also self-care for themselves, for the caregivers, because it can be very torturing to see your parent not recognize you, Jane.